Brilliant. So hi everyone, and welcome to our webinar called Recovery in the Time of COVID, What Now for the Mental Health of Our Healthcare Workers. My name is Susanna Bazile and I am Head of Programmes here at Doctors in Distress. As you can see, we have a very impressive panel of speakers for this evening, and I'm sure you are all very much looking forward to hearing their insights on this topic, as am I. And we're also extremely grateful to Alexi too for moderating our event. But before I hand over to Alexi and the panel, I just wanted to speak very briefly about Doctors in Distress and the work that we do. So Doctors in Distress exists to provide spaces and time for healthcare workers to talk. These groups are spaces where healthcare workers can come and share the stresses and pressures that they are facing without judgment. So often, healthcare workers feel that they are not able to do this, so these spaces are invaluable where they can share honestly about how they are feeling. So our charity was established after the tragic suicide of Dr. Jagdeep Sidhu, a consultant cardiologist who took his own life, feeling that he wasn't able to share about how he was feeling and how his mental health was. Jagdeep's brother, Amandip, then established the charity to ensure that no healthcare professional felt that suicide was the only solution to coping with their mental health struggles. So if you would like to hear more about what we do as a charity or to donate to our work, please do visit our website or follow us on social media. I can just see that the link to the website has been put in the chat box. And just on the chat box, it will be open for all of the event. So if you have any comments, questions, you'd like to say anything, please just pop this in the box and it will be monitored throughout the event. So without further ado, over to Alexi.
Thank you so much, Susanna, and welcome everyone to this important and timely discussion on recovery and mental health in the time of COVID. It's timed brilliantly to coincide with Mental Health Day, so it's a great event to have on around this time. I'm Alexi Mostrous. I'm an editor and partner at Tortoise. Susanna says she's grateful to me for hosting this event, but I'm grateful to her and to Doctors in Distress for the chance to be involved in this discussion, because it's trying really hard to get to the bottom of a troubling and complex picture. And we're a slow news company at Tortoise. We try and look beyond the headlines to what's driving the news. So hearing from people on the front line who know what's going on, as we do have in this incredible panel, it is really important to come to a more complex understanding of this issue. So just before I introduce the panel, I wanted to say that we're going to try and run this discussion a bit like a Tortoise Think in one of the events that we host online, and that means that we really would like to hear from you, the participants. In addition to the panelists, we want to hear what you have to say, your own experiences. Maybe you have something to say about mental health in the NHS. And if you do, please type your thoughts into the chat bar, into the Zoom chat bar, and I will try and kind of bring you into the conversation. So with a little bit of technical luck, we might be able to turn the camera on you if you're willing, and you can make the point to the panel yourself and directly. And we found that works really well to kind of have a collective knowledge that will let us have more of an understanding of this topic. So please do write your thoughts in the panel. Okay, look, it's almost time for me to shut up and turn to the panelists, but it's clear that what we're dealing with is incredibly serious. No one who reads the papers or who has a friend who's an NHS worker or who has in fact lived through the pandemic can be confused about the impact that COVID-19 has had on Britain's healthcare system. And some expect the next stage of the fight will be even harder than what has gone before. So having a system that protects and nurtures mental health in these extraordinarily difficult times is absolutely vital. And hopefully by this discussion will show us a few ways that we can strengthen that going forward. Okay, I'm going to go around the virtual table now and then introduce the guests one by one, and maybe ask them to say a few words about themselves and a few words about the topics that they're really passionate that they want to discuss over the next 55 minutes. So can we start with Claire Murdoch, please? Claire, hi, and thank you for joining.
Hi, good evening, and yeah, a pleasure to join. And a really important day, World Mental Health Day, and the whole week, in fact, where we reflect on the things that you've said. So I'm the National Director for Mental Health in England, at NHS England. I'm also a registered mental health nurse now for about the last 38 years, and better mental health has been a burning passion of mine for, yes, nearly 4 decades. And I'm also the Chief Executive of an NHS Trust. So and a mother and a sister and a wife and a member of society. So, of course, I see mental health in the round. Before the pandemic, I came into post. Simon Stevens brought me into post, really saying implement the 5-year forward view, which others had created with money and some deliverables, as it were. And that's turned into the long-term plan for mental health, which my job, put at its most simple, is to work with colleagues across the country to turn £2.3 billion a year every year additionally into our ability to see 2 million more people a year across the age ranges and different disorders and with different problems by 23-24 every year thereafter. We think that will take about 27,000 more staff as well. So it's recruit, expand and transform. So it's not just more, it's more and different. So we were rattling away at that. We're 2.5 years into the plan. We've got 2.5 years further to go. COVID has come, and of course, in many ways, has, thrown everything up in the air, whether that's for our brilliant workforce and workforce working in third sector and other colleagues as well. It's been a demanding time, but also what it's done to the nation's mental health. And I guess the things I'm really keen to explore are, how do we not pathologise and medicalise all of the distress that has come out of COVID? How do we not create a narrative of doom and despair whilst being authentically tuned into really what the challenges are? And how do we work with employers, schools and a whole range of other people whilst I and my NHS colleagues get on and deliver the long-term plan and the expansion and the workforce growth and everything else? And how do we look after ourselves whilst we do that?
Thank you very much. Well, there's lots to go at, even from that brief introduction, but maybe we can come now to Suki Thompson, the CEO of Let's Reset.
Thank you. It's lovely to be here. I feel a little bit more of a fraud because you are both amazingly involved in the NHS and in the psychological well-being and mental health. I come at it from a slightly different point of view. I feel like I've got the best job that I've ever had. This is my 4th business that I've set up, and prior to that, I was running big transformation programs for businesses, particularly marketing teams. And I felt increasingly that we would run these big transformation programs, but people wouldn't enable themselves to adopt them. And they didn't do that because we didn't change the culture. We didn't change the culture because people didn't have the energy. And that then made me focus on their well-being. Why is it in businesses do we not focus on the well-being and mental health of our people to make them more effective? So I set up Let's Reset to do that. I think alongside on a personal front, I have a daughter who's a trained psychologist and she works as a PWP. She's only 23, but she absolutely loves being a psychological wellbeing practitioner and very much at the beginning of her journey. So I've seen it from that side. We employ a lot of psychologists and mental health experts at Let's Reset. They work alongside business professionals as we go into lots of businesses and put in proper programs to really make a difference. And then personally, I've been on a journey, I think 13 years ago. I was one of those mums like you, Claire, a mum, a sister, a business. I had a previous business and I was diagnosed with cancer. And for the last 13 years, I've been diagnosed it 5 times. I have a genetic form of cancer. And so I have been increasingly looking at my own well-being and that of those people around me, as I also have tried to build businesses. We work a lot with teachers, we work a lot with dentists, we don't really work much with doctors, but I am really keen to look at 3 things. Like you, how do we look at the real strength in the NHS? What makes people so brilliant to be able to do this job? We see this a lot in high performance companies and cultures, and how can we help them use that? What do we do about attracting people into the NHS? It's exactly the same challenge we have in industry at the moment. There just are not enough people and they're not staying long enough. And then I think thirdly, as you say, Claire, how do we look after our own well-being and make it a real priority and not believe that we are invincible? Thank you very much, Alexi.
Thank you. Wow, what a great intro. And finally, can we come to Ananta Dave, please?
Yeah, thank you, Alexi. My name is Ananta Dave, and I'm a medical director at Lincolnshire Partnership NHS Foundation Trust, which is a mental health organization in the East Midlands in Lincolnshire. And I'm also a consultant psychiatrist, and I've worked in the NHS for over 25 years, which is when I came to the UK. So I'm a first generation migrant to the UK, and I've now been working in the NHS for that long. Now, I'm also, for the purposes of this meeting, representing doctors in distress as one of their trustees. So for me, this is hugely important at various levels. Even before the pandemic struck, during the course of my work, I'd become aware of how important it was to look after the mental health and well-being of staff if we are to deliver very high quality care. So you can't have high quality care without healthy and well looked after carers, in this case, professional carers or healthcare workers. And I just became more and more convinced that we have to look after those who are providing the care first if we are to change the kind of care that we deliver. And having lost colleagues and friends to suicide over the years, very often I have thought to myself when I look at my other colleagues, there but for the grace of God go I. So any of us can be caught up in a very difficult situation. And unless we feel that we are part of a culture where help is possible, where it's okay to ask for help, where we are not going to be shamed or where we are not going to be made to feel guilty by asking for help or saying we are not well, saying we are not coping, unless we challenge that kind of culture and promote a more caring culture, we are not really going to grasp this by the nettle and solve it. So before the pandemic, I was awarded a Churchill Fellowship, which was one of the fellowships awarded nationally to research on various topics. And I traveled to the US to do work on preventing doctor suicide. So when Doctors in Distress was set up as an organization at the same time, it really spoke to something which was very close to my heart. I just lost a close medical colleague to suicide a few months before I applied for the fellowship. And I just refused to accept that, we can't do more. I felt there was something that we could do together and at an individual level in order to address this, not only mental health problems and well-being, but, to stop people becoming unwell to the point where they felt that taking their lives was the only option or the only way out. So for me, it really resonated when Amandeep Sidhu set up Doctors in Distress, and that's how I came to be involved as a trustee. So my interest is, at an organizational level, over the last 18 months, especially, I've seen how COVID has intensified the pressures and the moral injury, if you like, on healthcare professionals, the difficult decisions they've had to take and work in an environment where resources are stretched, and what that has done amidst the loss, the bereavement, the grief, and the work pressures to their mental health and well-being. So at an organizational level, I know that if I want my staff to work well, I've got to look after them and make sure that they've got the right provisions. At a wider level of the NHS, I know that if the NHS is to be sustainable and continue to provide good quality care, we need to look after the staff. So there is an ethical, economic, and an evidence-based case to be made for looking after the mental health and well-being of our healthcare professionals. And that's what I'm trying to do as part of my job. Thank you.
Thank you so much. Thank you so much. Well, three amazing intros there and lots to get into. Ananta, can we just stick with you for a moment? And let me just stress straight up that Doctors in Distress isn't a charity just for doctors. It's for all medical professionals. But I think that your research focused on preventing doctor suicides. And you talked about promoting a more caring culture as being part of that. Pre-COVID in the NHS, from your experience, how caring a culture was it?
It varied and still does vary enormously. I think there are some places and organizations where the right cultures are in place. But on the whole, I would say that medicine as a whole, so although I'm talking about doctors, this encompasses all healthcare professionals, is a place where I think right from training, right from medical school days or nursing school, right from the days when people enter undergraduate training, somehow there is an equation that if you have a mental health problem, you're not good enough to cope, you're weak, you're not going to last the course, you won't be able to deal with the pressure, you're not competent enough, and you shouldn't be asking for help because you should be able to get on with it. So I think there's such an internalization of the need to be perfect or always coping that some unfortunately sets the tone. And although there is more work being done now, I think we can do much more right from the time when somebody enters at undergraduate level to send a very strong message that actually asking for help or saying that I'm not well is a sign of maturity rather than weakness. It denotes strength rather than an inability to cope. And seeking help early on prevents problems from worsening and becoming much more entrenched at a later stage. So I feel that we do have a way to go before we can say that we've created those caring, compassionate cultures as a whole. I mean, there is short-term work to do in terms of each organization looking at their own culture and support systems and seeing what they're doing. But I think if we are to make a sustainable change, the place to start is when people enter the training day, at that training and student days at that level, where we have to make it normal or part of business as usual to talk about mental health, well-being, where senior leaders are coming up and saying, yes, I've been there too, and you can't get out of it. It is possible to get help. I think it's good that you're asking for help. So those kind of normalizing conversations, encouraging conversations, talking about well-being and, preserving your well-being before you become unwell, having focus on healthy lifestyles and cultures, all that is hugely important. I think we have a way to go. Although we are getting there, I think we've started doing more actually in the wake of COVID, and we have to grasp the opportunity which has arisen from the devastation of COVID.
That's really interesting that you look at COVID as an opportunity as well as a threat. Just talk to me before we turn to the other panelists. Just talk to me a bit about how consistent early stage support is across the UK. Does it vary significantly depending on area and trust? And if so, what can we do to level that out?
Yeah, I mean, we have come a long way. So for example, we have organizations like Doctors in Distress who are providing reflective spaces and sources of support for people who want to reach out. We do have other voluntary organizations who work in the UK, organizations like the British Medical Association, the Royal College of Nursing. So there are other organizations who are providing sources of support, all the various royal colleges as well. And even at university level, we have things like the Practitioner Health Program for those, and it's a national provision for those who have significant mental health problems, drug or alcohol addictions. Apart from that, now we have, say, for example, things ranging from mental health first aid in various institutions to helplines, confidential helplines, and a range of staff well-being services. So this is a voluntary service which is run in most organizations. It could be called something different. It could be called staff health service, staff well-being service. But it is something which enables people to seek confidential help from trained professionals in the workplace for early problems, early onset problems which can be dealt with at that non-specialist level. So ranging from those to occupational health services within healthcare organizations, there are a range of facilities available now for people who are wanting to seek help. I think the issue is to make sure that, one of the issues that I really want to work with is how do we address inequalities in both in provision and access and culture. So there are certain groups of people who may not feel as empowered to seek help as others. So how do we make sure that it is an equal playing field for all? So while services are available, sorry?
What kind of groups?
So for example, I would say, in some cases, males might feel that they're not, they should maintain a stiff upper lip and not really admit to being vulnerable or needing help. In some cases, people who are in training positions, trainees, students might think that if they seek help, that's the end of their career. they're going to be marked negatively. They're not going to progress. Their portfolios will not be signed off, or the supervisors won't be happy. Again, there are people from an international background or a Black, Asian, or minority ethnic background who might feel that if they ask for help, they will further entrench already held beliefs by others that they're not good enough, they don't belong, they can't cope with the culture. So for various reasons, there are various groups. People having alcohol and drug problems might feel stigmatized already and be very reluctant to talk about their problem, and therefore leave off help seeking till late. And so there are various groups which might be, unequally represented or feel as if they can't seek help. So there is something about making this help, or these various layers of help, equally accessible for all, equally destigmatizing for all, and consistent, so that the quality that is offered is of a fairly consistent standard. So I think that's the thing that we need to get right, the leveling up.
Thank you so much. We'll come back to all of that. I'm noticing in the chat that already good points are coming through, so keep them coming. There's someone called Sheila who may want to come onto camera. I think we're just checking, has said, I think that there may be even more burden and distress with the seeming emergence of a possible new strain of the virus sweeping the country that is already making people feel shattered. Well, I'd love to hear from you, Sheila, if you want to come onto the camera and make that point to the panel yourself. But let's go to Claire now, Claire Murdoch, if we could. I mean, you're in charge of the entire NHS mental health services, so it's almost a question of where to start with with questions for you. But can you just give me a sense before COVID of where you saw mental health provision, how sophisticated and fit for purpose it was, and particularly in relation to any evidence that you saw in respect of the medical profession as a kind of self-contained category?
Yeah, thank you. I mean, I think it's no secret that mental health has been underfunded for years. There hasn't been that parity with physical health that we all ought to expect. And that means that we have an unmet treatment gap. And we work with researchers nationally and internationally. I work with some brilliant people, both in the national team, but also experts across the country and elsewhere, who help us understand what that treatment gap looks like. And for example, when we began our long-term plan journey 2.5 years ago, we were seeing roughly 1 in 3 children and young people who had a diagnosable mental health disorder. And we have got a really ambitious plan to double the numbers that we see, both the investment, the staffing, and the numbers that we're able to see in services by 23-24. But, imagine saying we see 1/3 of all diabetic children in the NHS. It just would be unacceptable. So I come to my role with great humility, but massive determination, because we've got this chance. We want to see, we've got a really clear and granular plan about the numbers of children and young people we'd like to see. The NHS mental health services, we all hear about the targets, the waiting time targets, I don't know, in A&E or for outpatient referrals. And, they can be a source of stress, I know, for professionals in terms of trying to implement them. But mental health didn't really have those access and waiting time standards until very recently. And we really missed them and suffered for it. So now we do have some. We got our first ones 2 or 3 years ago. So things like we've set up child and adolescent eating disorder teams across the country in the last 3 years, which is incredible, thanks to colleagues' hard work. And we've said that urgent referrals should be seen within a week and routine within 4 weeks. We've got some access and waiting time standards for IAPT. We've got some waiting time standards for UEC, A&E. But we've got such a long way to go. So our ambitious plan to see 2 million more patients a year by 23-24, specialist perinatal mental health services, community mental health services. I think that's the other thing we suffer from, that when we talk about mental health, often people think of it as one great big blob. Well, it's lots of different patient populations, lots of different groups. So we've got this really clear plan. And I guess for myself, and I think colleagues working in mental health, you will always find people who will talk to you about the access difficulties or the patient who didn't get seen. And that really hurts every time I hear it. It's what drives me on. But it is a fact that if you've got a treatment gap, you've got to close it. Now, Amanda Pritchard, the new Chief Exec of the NHS, just as Simon Stevens before her, is absolutely determined that we stay on that journey. We're rolling out, for example, mental health support teams in schools, where we're training people like the PWPs that your daughter is, Suki. They have, they're mainly graduates. They get a year in service and university and start there, and we're rolling these teams out in all schools so we can work with parents, teachers, local community, primary care, and by 23-24 we'll probably have them in 40% of the country's schools from nowhere 2 years ago. Should I celebrate 40% or should I lament 60%? And I guess I'm going to do both. And I think that some of what I experience in my national role about what we do and the joy and celebration of what we've achieved, and then what we don't do, what we can't yet do, and how hard that is and tough it is to bear, I guess that's borne out by clinicians every day in the front line. And for doctors and other medical professionals in particular, I've never worked with a colleague who lightly, doesn't see someone who could benefit from seeing them. But obviously we've got to prioritise the sickest or those most in need. And those judgments day in, day out that colleagues are making is something that I'm in awe of. I think the other thing is, talking about doctors saying their own mental health, and it talks to what we heard earlier. In 1983, an MP called Chris Smith stood up, and on his maiden speech in the House of Commons, he stood up and he basically said, these are my political aims. This is what I hope to achieve as an MP. I think he was Islington. And he also went, and furthermore, I'm gay, get over yourselves. But he was the first MP to stand up and come out as gay in the House. That was 1983 or 4, and the year I started nurse training. In 2012, so 30-something years later, I was driving home from work one night. It was about 9 o'clock at night, really tired, one of those days where you're just tired to your bones. And I was listening to Radio 4, as all good middle-class NHS managers do, And this programme came on, and it was the news talking about how 2 MPs had stood up in the House that day and come out as having a mental health problem. And I cried as I was driving up, up to where I live. I cried. And when I got in, I emailed both MPs. I just looked up on the internet their practice, where their surgeries were, and emailed them and said that was a hard thing to do as an MP. Bravo you. Both men had emailed me back before 6 o'clock the next morning, because I'm imagining they felt exposed, were glad of the support. And I think that we always talk about mental health as something other. I am really worried about disadvantaged communities, economic poverty, and the impact that has on mental health. But I think we need powerful people, which doctors and medical professionals are seen as having power. People in CBI and industry, leaders, I think, need to also be able to say, yeah, I've got mental health. We've all got mental health, and sometimes our mental health is better than at other times. And I think increasingly, the last thing I'd say is in mental health services, increasingly, we're developing both peer support workers in the mental health workforce and beyond, who are being employed for their lived experience, and they're potent and they're brilliant. But we do also employ a lot of staff who have mental health experience, and I'm not sure they know how to always A, ask for help for themselves, but B, how to use their experience in the organisation to help change the organisation. So I think there's something we need to do there to work with our doctors and others. Sorry, the last thing I would say is we have set mental health hubs up across the country as a result of COVID in every STP or every area across the country for health professionals And the notion is that they'll work closely with local health services, whether that's primary care, community, acute, mental health, and that we set out the routes for easy confidential access to NHS care. But we are working with practitioner health and others on perhaps professionals who come forward who have more complex problems where we can refer through. So I'm hoping one of the legacies of COVID will be, I've never seen people talk about mental health more. I've watched the news at 10 and the public have been asked, so what do you think about schools closing for longer, or for, I don't know, lockdown going on for longer? And the man and woman on the Clapham omnibus has so often gone, well, I'm really worried about the mental health of, and it's like, yes, people are finally talking about this. And I think we need to take the opportunity now to burrow deeper into how we all understand better mental health and support each other.
Thank you so much. But I want to come to Suki, but before that, I'd like to come to Sheila, who's making a good point in the chat. But before that, I just wanted to ask you a follow-up question, Claire, which is, is there evidence that doctors and other medical professionals have a particular issue around mental health? Chris Healy asks in the chat, does the NHS know how many doctors commit suicide per annum? Is there duty to report such an event? And in the course of my research for this event, there were some stats that suggested that doctors were significantly more likely to die by suicide. There's stats that suggest that a third of trainee doctors in the UK are feeling burnout. There's stats that suggest that even before COVID, there was a massive problem with burnout across the NHS. And as the person in charge of NHS services, do you have particular concerns about doctors, nurses, NHS workers and mental health? And if so, are there any plans specifically to target that sector?
Yeah. So as I said earlier, one of the things we have done in COVID, which I hope will be a legacy, is set up these mental health hubs, 42 of them across the country for health professionals, which we've never had before. They're NHS hubs. And that is because we recognise the particular vulnerabilities of certain professional groups within health. So yes, doctors do have a higher incidence of certain mental health problems, suicide. I think we have to be very careful how we talk about suicide, actually. Nurses slightly higher still, actually. So I think we've talked a great deal throughout COVID with people like Professor Greenberg, Professor Wesley, some of the great brains, as it were, who look at issues such as suicide, depression, anxiety, sleeplessness, burnout. And of course, we're concerned that this additional burden has really caused certain sectors within health to be particularly vulnerable. I think the thing that we're trying to look at is what are the things that will help most. Now, I personally think one of the things that will help most, and I'd love to hear from people on this meeting tonight, but one of the things I hear most reported is workforce and understaffing, that most health professionals, if they're going to work and they're working with their team and they're at full complement and you've trained together, you've cried together, you've planned together, you've thought about where you're taking your own service together and with partners over the years, it feels infinitely different from if you're running at high vacancy rates, high locum usage, agency and bank. So certainly for me, the issue of workforce and team is vital. Certainly there's lots of research that suggests above all resilience resides within teams. And I think we have to be very careful about what we place on individuals. You're coping, you're not coping. You know, I think most of the research suggests that strong teams help individuals and individuals make up strong teams. So full staffing, team ethos, proper supervision, time to make sense of what's happened on a shift, even if it's huddles, even if it's, you know, the temptation is to leave a dreadful shift or end a dreadful day and just go home and collapse ready for the next tough day. But actually the debrief, what went well, thanking each other, you know, taking a little bit of extra time can make a world of difference. So just a personal story. When I was a student nurse at the Royal Free, I attended a cardiac arrest, and I happened to be the first nurse on site. And I was only a second year student. I didn't, for a few seconds, I just didn't know what I was doing. And a staff nurse arrived from another ward, and I helped her with the resuscitation and was beginning to pass her stuff from the black box and what have you. My hand was shaking so much that as I passed her, and we worked on this man together, as I passed her the instrument she needed, she squeezed my hand at one point. It was a nanosecond, and she just went, "You're doing brilliantly." And on we carried. And I, to this day, 30 years later, have never forgotten that. And I think we have to try and think how, even in a life and death situation, those things mean the world to each other, and what goes on in teams and how we recognise and treat each other helps. I'm not saying that's the whole answer, but I think we have to really focus on teams in our workforce, as well as rapid access to help.
That's a great point to segue, hopefully neatly, to Suki Thompson, who's been waiting very patiently. Can I ask you to wait 30 more seconds while we bring in Sheila, who has also been waiting to speak, but we really want to hear from the members as well as the panelists. So Sheila, are you around? Can you make your point? If not, don't worry, I'll come to Suki first. Just wait a couple more seconds.
Unmute. Do that. Yeah, got it right.
Hey, how you doing?
Yeah, I'm here. Yeah.
Make your point to the panel.
Right, my point is there's been a lot of discussion, obviously, about distress and all that. But has anybody actually noted the news? I thought it was actually scam news to start with earlier today. It's now in the main news about this virus spreading through the country, that may be another variation of the virus. And I'm very worried because it's actually been on the I haven't seen it on the news yet, but if you go on the London news, it's there, and other news channels that it's there. It's actually there.
So thank you very much. Let's actually put that point to Suki. I guess what Sheila's saying is that COVID has been just one thing after another, and just when you think that you're getting used to it and you're handling it, something else comes along and kind of destabilizes you. And I wonder if you could just talk a little bit about how, if you were advising a business, what kind of things you would be telling them to cope with this kind of inherent uncertainty that has been injected into our lives over the last 2 years. And then, because there's the doctors and nurses and medical professionals discussion, just talk a little bit about how far you think the teachings that you provide to businesses can be transferred over to this sector.
Yeah, thank you for that, Sheila. Yes, of course it is. Look, it's very worrying, isn't it? Every time we think that we might be okay, we might be able to take our masks off and get back to some sort of, life, something else happens, and it is very hard. And I think what we're beginning to learn is that there is no certainty. But the bit that is important, and we know this with our mental health and our well-being, is that trying to live with uncertainty becomes increasingly important. And through that, we become more resilient. And I think to Ananta, your point you said at the beginning, one of the ways for us to address mental health within the NHS, within this kind of broader environment, is, of course, we need to educate people. Right at the very beginning, my daughter was at university. I've got to say, in all her modules, she had about one afternoon on a wet Friday where she was taught about her own well-being. When we went into lockdown, and by the way, this was her university. I saw this across loads of businesses that frankly should have known better. There was almost no interaction about how were they? Were they okay? How were they coping with this? Nothing. I've got to say, in her trust now, they're brilliant at it. It's an integral part of their learning, and I'm very impressed with it. But I think, Claire, to your point, and Alexi, what you were asking about is, you can only manage what you measure. I think it's fantastic that we've got some really good now, you're talking about it, Claire, it's brilliant that you have got some measurement, you have got a way and a direction that you're going in. It's exactly the same for business. So in business now, we've got the broad ESG, if you like. For those of you that don't know what ESG is, it's the environment measures that you put in place. It's the social, which kind of looks at mental well-being, and D&I. And then you've got the governance side of it. And that has, you know, COVID has really, really helped everyone have this conversation. And Ananta, you know, I think that whilst it is really important for doctors, for, you know, other medical staff to have the help and support when they are at crisis, what we need to do, I think, Alexi, I don't know what you think about this, is that we need people to think about their own well-being before they get to that place. So, you know, doctors, psychologists, they need to be at that place where they can have open conversations. But also, so we have a measurement tool where it's a kind of development of Maslow's hierarchy of needs. It's been used by a lot of psychologists. We use it in a school for some time, and it looks at 7 things. So it looks at security. It looks at autonomy and control. We know for doctors, nurses, medical experts, autonomy and control, vitally important for people to feel that they're looking after their well-being. You know, as you were just saying in your question, Sheila, if you feel like you're in control, it's easier to cope with another form of the virus coming along. Relationships, really, really critical. Having creative outlets, really important. Mental and physical well-being, and of course, purpose. And I think that one of the challenges in the whole of the NHS is now, because we've shown a light on how amazing you all are, you're absolutely extraordinary, but we've still got this in the back of our heads, oh yeah, but you've got a real sense of purpose. So it's okay if you're understaffed. It's okay if we don't train you in really looking at well-being, because you're still going to do it anyway. And I just don't think that that's okay anymore. I think it's got to fundamentally, we've got to have a very different point of view, in the same way that it's utterly unacceptable for businesses now to not run proper programs to help people manage their well-being to increase their performance.
So, Suki, you talked about metrics, and that's really interesting, because as you said, Claire mentioned it as well. And I like the phrase, you can only manage what you measure. If you're talking to a company that says, I would really like to improve mental health provision at my company, what kind of, I mean, in practice, what kind of measurement can they put in to look back at the end of the year to measure whether or not they have or not?
Yeah, well, they need to do a number of things. And you both talked about this before. Their senior leadership need to openly embrace the conversation. So, for example, in McDonald's, Paul Pomeroy he's the chief executive of the UK and Ireland currently, about to go into a European role, very openly wanted to talk about his situation. He began to see a psychologist a number of years ago and a counsellor to help him around some stuff now that he was becoming a dad. Part of that was to talk to his staff, part was to talk to me on a podcast that I do on a regular basis with leaders about this. You know, he had 23,000 downloads of our conversation that went to people. So, you know, you've got to have leaders embracing it and willing to talk. You then need to be able to put a structure in place. So in the same way that all businesses, in the same way, Claire, you were talking about measures you have, businesses have KPIs. You need to have business KPIs that you can measure, but you also need to have what we call a future fit plan. So it links against to our 7 needs of wellbeing and performance. But you know, companies like TUI and Benefit Cosmetics are putting those in place now, making a really big difference. And then you need to have people take their own responsibility as well. It's not just the business. In the same way, it's not just the NHS who've got to, you know, take responsibility for everyone employed there. We need to empower people. But, you know, like a PWP can help people with, you know, at that very basic level, with people with some mental health issues. We can teach with the right experts, which I love the idea you've got people going into schools. We can do the same thing in businesses. We can teach people, you know, how to basically think about their own well-being. And that's a really important way of doing it.
And Suki, I know that you work both with big corporates, FTSE companies, and with teachers and with dentists. And I wonder whether you saw a any difference in how to implement mental health provision as between kind of corporate entities on the one hand and state-funded institutions on the other? Are there different challenges?
Yes, time. Time and money. So let me tell you about Mike. Mike is a northern head teacher. He's brilliant. He oversees a number of schools, and we were doing a number of sessions with them. First of all, their 7 needs, and then we were doing some work with them about how could you put something into your school. And we did the first session with him and a bunch of other head teachers, and they scored themselves. And he sat there in the middle of the screen like this, and he went, "Hey up." And that was about all I got out of him for a whole 2-hour session. And David Beanie, one of our mental health experts, was there with us as well. And then 3 weeks later, I thought, right, I'm going to go for Mike first. We're going to see how he got on. I said, "Mike, how'd you get on?" And he did a big sigh, and then he went, "Well, do you know what? I was on the edge of burnout and I had no idea." And I said, "How do you know?" And he said, "Well, I did that scoring thing that you gave me, and I went home and said to my wife, I think I'm close to burnout." And she said, "Yeah, I know you are. And we all know this, but we didn't know how to tell you because you love your school, you love your job, you don't have time to take a break. During COVID, it's been one crisis after the other. You've not stopped for a moment. And we didn't want to make you feel like we didn't share how important your job was." And he said, "I'm going to take it was maybe 2 weeks, it was definitely a week." He said, "I didn't look at an email for a whole week." He says, "I've come back," he said, "and I feel amazing, but I hadn't even realized that I was almost there." And he said, "I lied when I did my first test." He said, "I did it again at the end of the week to truly do the test to see what score I'd get out of 70. And now I realize, I need to implement something like this for everyone, because you get to that place where you just don't know. And the problem for teachers and medics and dentists is that they are driven by passion. They don't have the same amount of money often to put extra help around them, and they just don't have even time to think about what are they going to do for themselves.
That's so interesting. I'd like to know what happened to Mike.
He's doing brilliantly, and you know what? They put an amazing program in place, but their problem is one of funding. They have so little money to then spare for a program. So you look at what a big company like Google. We work with Google. We work with O2. They have a lot of money, and even though we do it at a really discounted rate, and we're really happy to do that, it's still time and effort and resource.
Let's go back to Ananta, if we could, because you said something right at the beginning of this discussion, Ananta, which was about COVID being an opportunity, and that seemed like a really kind of interesting way of looking at it. So just tell me about, from your perspective, how COVID, because you're working on the ground, so you can see this. Like, how did COVID impact the mental health of the doctors and the nurses and the NHS staff who you spent time with every day? How much was negative and how much was positive, and where do you think we'll end up as a result?
To say that it is very hard to think of COVID as being anything positive. It's been devastating. It's just been unbelievable and unimaginable, loss of life, ill health, distress, trauma, bereavement. I think, it's very hard for any of us to have fathomed before COVID struck us as to what we would be facing. Out of the greatest tragedy can sometimes arise things which change the course of our lives, or which make us think about things differently. And as Claire alluded to during her talk, we are now talking about mental health in a way that we didn't prior to COVID. And we need to make the most of that. So this shouldn't remain at the level of lip service, but actually translate into a very different way for organizations to work. I mean, there are two things. One is that it is now, I think, not felt as, it doesn't feel as isolating and as stigmatizing and as guilt-inducing to talk about being affected by COVID, or even indeed, even without COVID, to talk about, being feeling the stress of work, being weighed down under the weight of decisions you've got to take, the pressure of lack of resources, the worry about seeing your colleagues unwell, worrying about your family, loss of, social connections, isolations. So, the impact of all these is being talked openly about. So it doesn't feel quite as isolating and quite as putting your head above the parapet to talk about these things, which is, we need to keep that up. The other thing is, people have realized during COVID, when we started losing healthcare professionals in the NHS or key workers, people realized that, the most important thing you can do to, combat COVID or come out of it is to make sure that you've got people left to deliver the services. So, whether it was about PPE, whether it was about, remote working facilities, whether it's about safe rotas, redeployment, shielding, all these various things were about protecting staff, people who were delivering services within healthcare, outside in supermarkets, wherever. So I think the importance of staff well-being as a means of delivering good healthcare became really pivotal. People realized it and people started looking at what needed to be done. So that's another thing which we should never lose sight of, even when we come out of this effect of COVID. The third thing is, as people have been saying, it's not just about people becoming mentally ill, things like long COVID, bereavement, exhaustion, sleeplessness. These are, as Claire said, these are not pathological conditions, but these play a huge role in not making us well enough to work or not being able to deliver things as we would like to. So people have become aware. So, there are bereavement services now in the NHS, which we didn't have before COVID on as regular a scale as before. It's real. I mean, if you look at the number of people who've lost their lives in the UK, and therefore, as a consequence, the number of people who are bereaved by loss of life or by loss of their function because of long COVID, for instance, or, because of seeing friends and colleagues suffering, it's a huge burden and a huge, onus on all of us to, do something about it. So I think, beyond pathology and illness, there is an awareness of how much it has cost us as a country in terms of our emotional well-being and, the impact on all of us. So there are some of these things which have become, and I think the other thing which has opened up during COVID, which impacts ultimately on health, is the role of or what it is we are doing to combat an unequal society. We have to accept society is unequal. Institutions are unequal, institutions are discriminatory, and that goes for the NHS and healthcare. And unless we are able to look this in, this in the eye, the truth, and accept that this is where we are never going to change it. So perhaps it has become a bit easier, not always, it's still a fraught topic and people are divided, but perhaps it has become a bit easier, a bit more common to talk about how unequal we are as societies and institutions, and that can cost lives. Inequalities cost lives. Institutional racism, institutional discrimination costs lives. So we've got to be able to say that for what it is. And so there are some of these things which have been highlighted as a result of COVID, which we would forget at our peril. And we should continue to keep them at the forefront of our thinking as we go forwards. And that is what I meant by COVID maybe teaching us a lesson about what it means to look at the cost of our policies and our institutional cultures on peoples.
I'd like to ask two quick follow-up questions, if that's okay. I'm really interested in the work that you did around preventing doctor suicides. And I wondered whether you found that there were any measures to lower suicidality in doctors that either worked or didn't work for doctors specifically, but that might not have worked or not worked for the general population. In other words, is there treatment or things that you can do in a medical setting to improve the life of the mental health of medical workers, which might not actually be that effective in the real world? Well, not in the real world. I mean, in the non-medical population. Yeah.
Got it. Yeah. And forgive me if I just spend a couple of minutes talking specifically about doctors. I mean, there are wider points which can apply across healthcare. But certainly some of the things that stand out for doctors is the huge burden of doing something wrong and facing the regulatory authorities, if you like. That's something, that's a cross that all doctors bear. So being referred to the regulators is seen as, the ultimate pressure. And I think certainly there are, as organizations, we need to make sure that there are policies in place which help us identify problems early, whether they are due to performance, lack of competence, ill health, conduct, whatever that is, that might be affecting a doctor. If you're able to intervene early, so, that's something which is being measured in the country as well. How many issues are dealt with at the level of informal disciplinary procedures? How many of them proceed to formal? How many of them result in being the doctor being referred to the regulator, the General Medical Council in the UK and other regulators elsewhere? So this burden is something which needs to be managed more effectively, and therefore early intervention, training leaders and managers in a way that teaches them about compassionate culture, equality, and addressing their biases is really important. And once somebody is referred to the regulators, what support are those doctors given? What is the, how do we work with the verdict and, the sanctions? How do we remediate doctors back into work? These are hugely important issues. So that's one thing which doctors are specifically worried about. And a lot has been written about the impact, the mental health impacts of being referred to the regulator. The other thing is what I would say is the power of listening to sensitively shared stories about senior leaders or managers having tackled mental illness or mental ill health or any kind of stress and come out of it. It is all too easy to have this idea of doom and gloom. Once you have a mental illness, that's it, your career is over. Those narratives are still quite prevalent, and people feel that I've been diagnosed with whatever it is, bipolar disorder, that's it, I can never be a good doctor again. And we really need to look at what people tell us, how empathic, how caring, understanding, and effective a doctor can be with their mental health problems, how it gives them fresh insights and perspectives. So it's very easy to talk about the weakness or the whatever the problems that arise out of mental illness. We need to talk about stories where people have come out of this, have shown great strength and courage, and have had wonderful careers. And, if we look at the world around us where doctors are sharing stories, senior doctors are talking about their mental health struggles and how they've overcome them, that has been the single biggest reason sometimes where people have sought help, because they've seen that their chief exec, their board member, medical director, nurse manager, line manager, professor has sought help and recovered. So that's really important.
That's so interesting. I can see Suki has her yellow Zoom hand up. And I also want to say that it would be great to bring in Dr. Lucy Henschel, who's making an interesting point in the chat. So if we could ask Dr. Henschel whether or not she'd be willing to speak, that would be great. And also, joy of joys, the Zoom will cut off at 7:15, not at 7, so we've got a bit more time to discuss all this. In time, in fact, for me to ask Ananta one more question, which is, Claire mentioned at the start that mental health provision has an extra 2.3 billion a year. There's lots of plans to bolster it in a lot of ways, some of which she outlined. Are you confident, how confident are you, Ananta, that that extra resource will allow us to, as you said, learn the lessons of COVID and transform mental health into something that is not simply paying lip service, as you put it, to the problem?
I mean, it's a combination of things. I think, it's very rarely that solutions have simplistic problems have simplistic solutions, So resource is vitally important. I mean, we've talked about an underfunded NHS and especially underfunded mental health services for a very long time. Having the right resource is important, and it needs to sit alongside the right culture, the right competencies, and the right service models. And all of them need to come together. So we need to be training people the right way. We need to be having the right cultures and leadership within organizations. And we need to make sure that services, whether they are for staff, patients, people, and communities, follow the right models with the right skill mix and the expertise and supervision and, reflective spaces, etc. So if all of these come together, yes, I think, we can make this work, and resource is one and a very vital part of it. I just want to spend the 30 seconds challenging, or just correcting I mean, I think when I was talking about bereavement, I said we shouldn't pathologize bereavement, but absolutely, you know, as somebody has pointed out, long COVID is not normal, and it is something which is arising from COVID. So absolutely, you know, that's you know, we can't equate the two, one bereavement and long COVID. You know, it's a pathology.
Well, thank you so much. Thank you so much for answering that. I think it would be great to still hear from Dr. Henschel, just in terms of her general point of view on this topic. But and then after that, we'll come to Claire, because she's so tapped into all of this that I'm sure she'll have some interesting further points to make. But first of all, Suki, you had your hand up.
Oh, it was just a very quick point, and I completely agree with you, Ananta, about, you know, if you can't see it, you can't be it. And it's really important that we do get senior leaders to have these kind of conversations. And I did a book, like most people do, 2 years ago, but actually all it was a combination of talking to over 100 leaders, predominantly in business, but we had some psychologists and people in the medical world talking about their experiences. So for example, somebody like Steve Hatch, who's the VP of Facebook in Europe. He had a psychotic episode when he was 26, and now he's the VP of Facebook in Europe. And there's another guy, Matt Atkinson.
But don't hold that against him, huh?
No, we won't hold that against him, but it's a pretty big job, hey. You know, Matt Atkinson was left for dead in Spain, having been just run over by a car while he was on his bike. Ended up in a trauma unit, and just recently has been the chief commercial officer at Co-op Group. So, you know, really amazing leaders that, you know, have gone through some extraordinary experiences, but they talk about the experiences they've got, and they have been able to carry on and have, you know, very, very preeminent careers.
Thank you so much. Lucy, can we come to you, Lucy Henschel? Ananta has kind of answered your point, but if you wanted to make another one or a broader assessment of where we were in mental health, then that would be great. That would be great if you could.
Hi, is my sound working okay?
Fine.
Fine, good. Hi, I'm Lucy Henschel. I'm a GP, but my interest is in supporting other GPs. And there were 2 points I wanted to make. One was just picking up on something Ananta said, and I think she perhaps misquoted something she didn't mean to say, and she can correct me on that. You referred, Ananta, to bereavement, for instance, not being a pathology, which I wholeheartedly agree with, and then included long COVID in the same sentence. And I just wanted to draw a distinction that quite clearly long COVID is something we don't yet fully understand, and I think it got slipped in there in error. My bigger point,
I think Ananta corrected that.
Yes, thank you. I'm so sorry. My sound, as I went upstairs to find my earbuds, I obviously lost the sound, so my apologies for that. The reason I mentioned long COVID, and I think it plays into the mental health agenda, the work I do supporting, in particular, GPs who return to work after time away or who are struggling to stay in work, and I also, as Ananta knows, work within practitioner health as a clinical lead. What I observe happening is people develop an illness, have an absence, get long COVID, have an episode of postnatal depression, whatever it is, and the system expects them to go back to how they were before. And so, are you better yet when you're coming back to work? And increasingly over the last year, I've done some liaison work with an organisation called the Vocational Rehabilitation Association, and it dawned on me as a GP with 30 years experience that I'd never heard of that. And so we have occupational health that very helpfully will assess a work scenario and an individual and say, you might need to work part-time, or maybe you should come off night shifts, or et cetera, because of your ongoing health issues. But in the health service, we lack the mechanism that enables that to happen. And the key word being enable. We've got this measure up to the standard expectation of ourselves and each other. And perhaps, you know, looking at the bigger industries, it'd be interesting to hear Suki's perspective. Places like Google will plough in early intervention to improve rehabilitation, and we leave it all to the individual in the NHS, and there's a gaping hole. And so I'd be really, really interested to know what all the panelists feel about that, and how do we bring that into the health service of the future? Because early intervention, funnily enough, we know in just about every aspect of medicine works. And expecting people to cure themselves of diabetes doesn't work. So why do we expect them to cure themselves of their bipolar disorder and go back to how they used to be? It ain't going to happen.
And
so
that's such an interesting point. And I'm getting from you that it applies obviously to things that aren't just long COVID. It applies to bipolar and a myriad of kind of mental health issues.
Yeah.
But is there an example that you can think of where a doctor has gone back to work or a nurse has gone back to work and their mental health has been taken into account? And if so, could you just give us an idea about how that might work?
I think, and it's core to the work I do, it actually starts with asking that individual, how do you think you might work best? What context and environment would enable you to thrive and not just survive? So perhaps with the insomnia thing, for somebody whose mental health problem involves a sleep disturbance, it can be life-changing if they're allowed to say, I really work well in mornings and you'll get gold from me if I work mornings, but don't ask me to do split shifts and rolling rotas. And I do, I know people who have returned to work with mental health disorders and thrived when their perspective of what would work for them is taken into account. And the conversation has to start with the individual, and it doesn't. It tends to start with the system requirements. And I appreciate there's a service provision and a workforce capacity and all of the other things we've talked about and that we've heard about this evening from Claire and Suki, that there's a big picture thing. But my view is a team is made up of individuals. If you don't ask each of the individuals, how can we support you to do your best work, given that you are prone to recurrent depression or suffer from agoraphobia? Don't ask somebody who suffers from agoraphobia to be the person who keeps scuttling across to the other side of the hospital between clinics. Let them work in a clinic in the same department. Really, really simple things that those individuals know and will describe and will ask for if somebody's listening.
Claire, can I turn to you on that? Because Dr. Lucy Henschel is making a fundamental point, isn't it? That it's not simply about getting people back to a stage where they can return to work. It's about having flexibility, the same flexibility that is evident in occupational health. How much are you thinking about this problem of a binary not fit to work paradigm when there should be much more flexibility in between those categories?
Yeah, I mean, so we talk about patients and every individual. Primary care sees 1 million patients every 36 hours. They're individuals, and we cannot hold that standard for the patients we see and not hold the same standard for our staff. They're individuals. And certainly there's a lot of research that things like control over your shifts and your working patterns, whether that's to do with how you feel emotionally, or you're juggling childcare, or you've got a course you really want, you're learning to sail on a Wednesday evening, and that's great for your mental health. You need Wednesday evenings off. Whatever it is, control over your working patterns is critical. I've never heard the term used as much as I have in the last year or so about compassionate leadership. And compassionate leadership is absolutely making sure that a whole team can work well and that people can feel connected to their colleagues. But it only works really well if you're seen as individuals. I think there are a myriad, and certainly I've heard a myriad examples of where people have been helped back really flexibly, either to a different role or fewer hours or different hours. But I think the point is our workforce, our colleagues are liquid gold. They are what powers the beating heart of the NHS. And if we don't look after them, people on this call and beyond, ourselves, we won't look after our patients. And I do think COVID has exposed that like never before. I do also think, if I might, just because I know other people will need to speak and it'll soon be 7:15. I do think that we have to avoid, the doctor or the health profession as hero or heroine. We need to move away from this Superman, Superwoman thinking and think about what really helps you. You know, Suki, your 23-year-old daughter, how will we keep her when she's 33 and 43, 53, or like me, nearly 63? What will be the things that will enable her and us to build upon skills? She might have babies, she might have a health problem, she might have a desire to travel the world at some point. How are we going to work with her and other health professionals to really think joy at work, compassion at work? I also did want to say, I did see some incredible things from clinicians and colleagues over the last year and a half. I mean, I've wept for colleagues that we've lost, literally wept, as we all have. But I've also seen massive innovation, clinical colleagues leading a change that they wanted to do for years. And suddenly it was possible because there was a permissive environment, and we were saying, whatever it takes to keep yourself safe and to reach your patients and to keep services going. And crikey, I did see things that just humbled me daily. And so I think we have to also keep a sort of permissive and empowered environment that doesn't tether clinicians and lets them do more of what they see as the right thing by their patients and themselves. So I think, as you say, it's hard to say that anything positive came from COVID, but some lessons have come from COVID so far that actually people should feel immense satisfaction in. They should recognise how incredible they were day in, day out, and there for their colleagues and patients. Some of the shift to digital, we all got highly technical, and some of that was absolutely amazing. And I know many patients are calling for a shift back to face and GPs. And can I just say to GP colleagues on the line, don't internalise. Whatever you do, the current battering, I so sympathise, but just turn it off, don't listen to it. You're doing incredible work. And many patients, myself included, will look after themselves better if I can have a digital appointment or a phone call with my GP. It's amazing. I'll actually be better because I'll be able to fit it in around my working life. So I think we've learned a lot and done a lot and achieved a great deal that was quite incredible as well. So I do need and want colleagues to, thank them. Well, what's the word? Applaud themselves, to recognise that in themselves and their colleagues, because people have my NHS colleagues have been amazing. I've possibly never been prouder in 38 years of being part of the NHS. So I don't want to turn people into having to be superheroes and heroines, but I do think it's truly important that people recognise the amazing work they do, because actually that's good for your mental health too.
Claire, I suppose part of the problem that people in the medical profession have is that having people's kind of sympathy and pride in their work only goes so far. And Sanjita in the chat raises the brutal counterpoint to everyone's admiration for people in the medical profession, which is, she says, a huge number of nurses have resigned from my workplace. The ones remaining are now overburdened. How will we manage this trend? So there's a real kind of present danger problem, isn't there, with burnout and mental health issues, particularly nurses, and how do you actually handle that here and now?
Yeah, so it's sort of, in my defence, I really waited till quite a long way in this debate to talk about some of what was amazing. And just to remind colleagues, at the beginning, I was talking about things like staffing levels, supervision, control over your shifts, huddles before you finish a tough day, compassionate leadership. We have got to attract more youth into the NHS. I think we have an opportunity. We have got to make sure we just don't run people into the ground, that their shifts are doable, their working patterns are doable, that we value them. So I think there are some intensely practical things that either we in the NHS or government must do to make sure that we've got sufficient workforce, the right workforce, and that workforce has genuinely compassionate leadership, control over working circumstances and patterns, and is able to look after themselves and each other because they're working within frameworks and with demands that are doable and deliverable. I think we all look at the winter ahead, and I think there is some trepidation about how busy the NHS will be. And yeah, we were COVID heroes, and now people are concerned about their elective catch-ups. We know in child and adolescent mental health services, we're seeing a surge. I think it's deeply practical things like enough staff, proper briefing, proper supervision, proper days off that we have to keep aiming at, because ultimately, though, proper training and development, etc., proper career breaks and enabling people to come back. It's those things. Actually, I think it was Simon Stevens who, before he went, said we often talk about this is a marathon, not a sprint. Actually, it was a sprint, and now it's going to be several marathons. So my son's just run the Manchester Marathon in under 3 hours this weekend, and it's bravo him. It's sorry, proud mum being a bit gloaty there, forgive me. But you know, he had to think about not just his training, his nutrition, his sleep, his hydration. You know, if we're doing several marathons in the NHS, and we've got to think about every aspect. For some clinicians, it was parking. It was, can I get a hot meal? You know, do I get adequate sleep and days off? We've got to value those deeply practical things. And I think many organisations are doing much more of that than they did a year ago. In fact, I know they are. But we have to seriously value sufficient workforce, right calibre, right values. And for me, workforce is the single biggest priority that the NHS has.
Thank you so much. Well, I've been told in no uncertain terms that we have to wrap up for the day, but we could have gone on for hours. It's such an important topic. It's just remains for me to say thank you so much for everyone that participated, not only Ananta, Suki and Claire, but everyone on the chat as well, and to Anne, Paul and all the team at Doctors in Distress for all the fantastic work that they do. We are delighted that Tortoises and Doctors in Distress are partners. From our perspective at Tortoise, we really want to put journalistic resources into investigating mental health issues, not only in the NHS, but outside it too. So if anyone has any ideas about that, please email me on alexi@tortoisemedia.com. And in the meantime, I think the best thing that has been said all day came from Fiorella Massey on the chat, who said, we all need our hands squeezed sometimes, which I thought was a lovely way to end tonight. Thank you so much and have a lovely evening.
Thank you. Bye.
Thank you.
Bye.